Just a quick note, the presentations, the full posters that each of the presenters are going to be discussing are on the SERGG website, sergg.org. And if you click on poster presentations, you can scroll through them in alphabetical order and click the link at the very top to view the actual large poster that they're talking about. With that, we'll go into the first presentation and get this going in full screen mode.
Good afternoon. My name is Katerina Abdallavija. I am a second-year genetics categorical resident at UAB, and we'll be discussing arginase deficiency presenting secondary to a COVID-19 infection. Arginase deficiency is caused by a decrease in arginase enzyme activity in the urea cycle, usually presenting a little later on in life with neurodevelopmental issues and very rarely being associated with life-threatening hyperammonemic events. Our case is of a 6-month-old male with no past medical issues who was taken to his primary care physician due to fussiness and decreased PO intake. Patient was subsequently found to be lethargic and taken to the emergency department where he was intubated and found to be febrile. On lab workup, found to be positive for COVID-19 and hyperammonemic in the 2000s. Due to this, patient was transferred to a tertiary pediatric center for further management. Here, ammonia levels were confirmed and patient was also found to be hypoglycemic, for which patient received boluses of IV fluids and dextrose, and genetics was consulted. Here, he was started on emergent dialysis, which decreases ammonia back to normal, and metabolic screening labs were obtained. The main finding in the metabolic workup was of an arginine level almost 5 times the normal limit. Patient was not on supplementary arginine at this time. Patient had imaging that demonstrated diffuse cerebral edema, and patient's neurological status remained poor in spite of improving lab values. Brain death was declared after 2 conclusive brain death examinations. On genetic test results, patient was found to be homozygous for a pathogenic variant in the ARG1 gene associated with autosomal recessive arginase deficiency, thus confirming the diagnosis of arginase deficiency. This is an important case because it shows a rare severe presentation of arginase deficiency that was unmasked by a COVID-19 infection. This is important because we do not have much information associated with the effects of COVID-19 on patients with inborn errors of metabolism. These are the references, and thank you for your time.
In the interest of time, we will obviously not go into questions right now. We'll go into the next talk.
Good afternoon. My name is Katerina Abdallavija. I am a second-year genetics categorical resident at UAB, and we'll be...
Sorry, next talk.
Elizabeth Barnby, and I'm here to talk to you about neurologic crisis in patients with hereditary tyrosinemia type 1. There are 3 common pathophysiologic mechanisms for this neurologic crisis, or 3 diseases that share the same pathophysiologic mechanism. Hereditary tyrosinemia type 1 is caused by autosomal recessive transmission of a genetic disorder leading to an FAH enzyme deficiency caused by a mutation on the FAH gene. This produces a non-functional FAH that causes toxic metabolites that include the production of succinylacetone, and this SUAC inhibits the ALAD enzyme, leading to porphyria-like neurologic crisis. The prevalence of this disease is 1 in 100,000. This disease shares a similar pathophysiology with ALAD porphyria and lead poisoning. ALAD porphyria is well known to emergency room doctors, and its prevalence is only 1 in a million. It causes the neurologic crisis by a deficiency of the ALAD enzyme, and is a genetic disorder as well. A similar pathophys is caused by lead poisoning or environmental exposure to lead that can also inhibit the ALAD enzyme, and its incidence is, believe it or not, 1/3 of the world's children, according to the WHO. All of these diseases cause similar neurologic crisis that can lead to very adverse outcomes. Thank you for listening.
The next presentation we have is from Dr. Tom Callis.
Hi, my name is Tom Callis, and I will talk about the yield and unexpected findings from combined cardiomyopathy and arrhythmia genetic testing. My disclosures are that I'm an employee and stockholder of Invitae. Genetic testing for cardiomyopathies and arrhythmias is now recommended by cardiology professional societies. However, the advantages of broad multi-condition panels versus condition-specific panels is not well established. Therefore, we sought to assess the yield and clinical utility of a combined cardiomyopathy and arrhythmia panel offered through a no-charge sponsored genetic testing program. We reviewed genetic and clinical data from approximately 5,000 probands who participated in the sponsored testing program, whose broad eligibility criteria consisted of having a suspected or known diagnosis of a familial cardiomyopathy and arrhythmia, a family history thereof, or a personal or family history of sudden cardiac death. In the cohort overall, 20% of participants had a pathogenic or likely pathogenic variant identified, while approximately half of participants had one or more variants of uncertain significance identified. The most frequent reasons for referral into the program was a suspected or known diagnosis of hypertrophic cardiomyopathy or dilated cardiomyopathy. Interestingly, for patients whose reason for referral for genetic testing was a specific condition, we found that approximately 11% of their positive results would have been missed by a disease-specific panel. Most of these projected misdiagnoses remained within the same broad category of the original diagnostic indication. For example, a specific cardiomyopathy was indicated, but the genetic testing identified a different cardiomyopathy. So in summary, we found that the combined panel identified a clinically relevant variant for 1 in 5 patients overall, and importantly captures more than 10% of patients who might have been missed by a condition-specific panel. This greater utility of the combined panel offers greater diagnostic benefit to patients, but is accompanied by a high frequency of uncertain results. Hi, my name is Tom Callis, and I will talk about the yield and unexpected.
All right, the next presentation is from Laura Davids at Emory University.
My name is Laura Davids, and I'll be talking about our research focusing on newborn screening and Pompe disease. In the summer of 2019, we distributed an online survey to genetic counselors, geneticists, newborn screening follow-up care coordinators, and nurse practitioners caring for patients with a positive newborn screening result for Pompe disease in the United States to learn about their experiences and opinions. We had 78 participants meet inclusion criteria. Overall, the healthcare providers were in favor of implementation of newborn screening for Pompe disease as a whole. The majority felt that the inability of newborn screening to distinguish between infantile onset and late onset Pompe disease placed a psychological burden on the family. General trends and other opinion questions showed that more healthcare providers felt that newborn screening led to better health outcomes on the part of the patient in individuals with infantile onset than late onset Pompe disease. Opinions were divided about whether reproductive benefit for parents should be considered as a justification for newborn screening, with more feeling this way in the context of infantile onset Pompe disease than late onset Pompe disease. Almost half of the healthcare providers faced 3 or more barriers during the confirmation period, the most common ones being time lag between newborn screening and confirmatory results, family resistance to seeking medical care, and insurance-based issues with laboratory testing. After a diagnosis of infantile onset Pompe disease, 1/3 of our respondents said they experienced 3 or more barriers in providing care. Following diagnosis of late onset Pompe disease, over half of our participants experienced 3 or more barriers in providing care. Barriers that are frequently encountered include insurance issues, family resistance to seeking medical care, uncertainty of when to seek treatment, and families lost to follow-up. Providers were significantly more likely to feel that their state had sufficient resources to provide follow-up medical care for individuals with infantile onset than for individuals with late onset Pompe disease. The most requested resources included greater pediatrician education in LSDs and official evidence-based clinical practice guidelines recommendations for individuals with late onset Pompe disease identified at birth, including specific monitoring schedules and when to initiate treatment. Thank you.
The next talk is from Dr. Teresa Douglas at Emory University.
There are
Thank
limited
you.
training opportunities for registered dietitians treating patients with inherited metabolic disorders. Evidence is lacking that identifies barriers affecting access by RDs to fundamental training and resources. We conducted a survey assessing the educational needs, resource availability, and barriers related to RD's pursuit for professional development and knowledge acquisition. Within our methods, we distributed an online assessment survey via REDCap to RDs globally who treat patients with inherited metabolic disorders. Questions focused on professional experience, types and availability of professional resources and growth opportunities, barriers, and interest in educational opportunities. Our results from 51 RDs who completed the survey showed that 55% had more than 4 years professional experience. However, 47% of those who answered had no training in inherited metabolic disorders prior to clinical appointment. 82% reported that most training occurred on the job, with 90% reporting they were primarily self-taught. 4 leading barriers affecting professional education and training included time limitations, reported by 84%, lack of inherited metabolic disorder specific education pre or post acquiring the RD license, as reported by 54%, few evidence-based inherited metabolic disorder nutrition guidelines, and limited institutional support, as reported by 48%. More than 90% respondents reported an interest in expanding the educational and training opportunities for their profession. In conclusion, inherited metabolic disorder specific educational resources prior to and during metabolic RD clinical appointment are currently insufficient to meet the profession's demands, and RDs recognize this gap. RDs desire more occasions to advance knowledge specific to metabolic patient care while overcoming recognized barriers. Case-based learning sessions developed by Emory University Department of Human Genetics in partnership with University of New Mexico's Project ECHO is one initiative tackling the described limitations.
And our next talk is again by Dr. Douglas.
Sapropterin is a pharmacologic cofactor for phenylalanine hydroxylase that lowers plasma Phe, thus permitting diet liberalization in a subset of patients with phenylketonuria, or PKU. Since fatty acids have many health and biological roles, fatty acid status in PKU patients' liberalizing diet should solicit attention. To determine diet liberalization's impact on fatty acid status in PKU, we analyzed food records and fatty acid markers across 1 year in sapropterin responders and non-responders. At baseline and 1 year, we analyzed 3-day diet records with Metabolic Pro and 57 plasma fatty acid markers by Kennedy Kruger Institute in Baltimore, Maryland. Sapropterin responders remained on sapropterin throughout the study year, while non-responders maintained standard diet therapy, both under the supervision of registered dietitians. Between group across time comparisons completed with multivariate ANOVA and SPSS 26 revealed significant 1-year declines in plasma omega-6 PUFAs, MUFAs, and trans fats among both the sapropterin responders and sapropterin non-responders, with no between group differences. Trans fat intake decreased significantly for both response groups during the study, and declining trends in dietary total fats, MUFA and PUFA intakes were also observed without reaching significance. Conclusion: reductions in both dietary and plasma fatty acids across time with minimal between group differences confirms that plasma fatty acids in PKU patients are impacted by reduced medical food and fat intake. Specific factors in diet liberalization and long-term health implications necessitate further study.
Thank you, Dr. Douglas. The next talk is from Beth Voretsky.
Welcome to the Family Voices poster, Moving Beyond the Family Engagement Checkbox, a framework and tools to promote authentic family engagement and systems change. Many healthcare entities, such as regional genetics networks, understand the benefit that families' lived experiences bring to improving current policies and services. However, many do not know how to engage families, especially diverse families, and provide the information and support they need to partner, participate, and contribute to decision-making groups. As a result, families say they feel like a checkbox to fulfill a requirement to be present rather than as a true partner. To address this issue, Family Voices created the Family Engagement and Systems Assessment Tool, a 20-item tool organizations can use to plan and assess meaningful family engagement. A companion Family Engagement and Systems Toolkit provides strategies and resources for improving family engagement efforts. Each document is organized by 4 domains of family engagement: commitment, transparency, representation, and impact. This slide lists examples of the key criteria in each domain and explains why it's so important. I want to focus on transparency, where we've seen organizations struggle the most. It's especially, for example, it's especially important to provide families that you want to engage, to provide them a role or job description so that they have a clear understanding of their roles and responsibilities. This is key to helping families move beyond the checkbox. It's equally important to provide a mentor, either within your organization or from a family-led or community-based organization. Mentors provide support and help families understand their role, feel confident in their partnership role, and how to use their lived experience to improve systems for all children and families. I invite you to download the Family Engagement and Systems Assessment Tool from the Family Voices website. They are available for free, and as part of Family Voices' commitment to meaningful implementation of these tools, we provide free technical assistance as well. Thank you.
Our next talk is from Rebecca Gibson of Duke University. It's not loading. So I'm having technical difficulties with Rebecca Gibson's presentation. So I'm going to have to move on to the next presentation. This is going to be from Saran Raj Guran at Emory University.
Good afternoon. My name is Saran Gurung, MNT for. Good afternoon. My name is Saran Gurung, MNT for P, Program Manager at Emory University. I'm here to present an overview of demographics served by MNT4P program in its first 3 years. MNT4P program is a unique patient-centered program dedicated for comprehensive care and management of patients and families diagnosed with inherited metabolic disorders in the state of Georgia. This program results in services related to medical foods, low-protein modified foods, nutrition-related supplies, and medical nutrition therapy, education, and counseling. In the state of Georgia, there is no legislative mandate for coverage of medical food by private medical insurance, causing financial burden on patients and families with IMDs. MNT4P aims to mitigate the burden by bridging the gaps in services for medical nutrition therapy. The patients with a confirmed diagnosis of IMDs needing help with medical foods, low-protein modified foods, and nutrition education and counseling were enrolled in MNT4P program. MNT4P services were rendered based on their needs. Data collected were analyzed on the back end. 363 patients and families were enrolled in MNT4P program in its first 3 years. 34% of these applicants needed brief supply of medical foods, 24% needed insurance navigation, and around 14% LPMF. 67% of the applicants were under the age of 18. Only 8% of the applicants were uninsured. 56% of the applicants had a diagnosis of phenylketonuria. The IMD community in the state of Georgia continues to experience inadequate access to medical food despite 92% of the applicants covered by medical insurance. It underscores the need for the legislative mandate for medical foods coverage by private insurance. Meanwhile, MNT4P program strives to create equitable access to medical foods and medical nutrition therapy, covering these gaps in care and management of IMDs. Thank you.
The next talk is from Dr. Robert Latour of Clemson University.
We have developed an at-home urine test for phenylalanine for persons with PKU and a breath test for ammonia for persons with a urea cycle disorder. We have conducted clinical trials for each of these test methods. The breath test was evaluated for kidney disease patients and compared with blood urea nitrogen values as proof of principle, with subsequent application for urea cycle disorders. For the urine test, urine samples were collected at the same time that blood samples were taken to check blood Phe levels. A test strip was dipped into the urine sample and then photographed with a smartphone camera after 1 minute. The color response was then analyzed by the R value of the RGB color scale and compared with the blood Phe level. For the breath test, participants exhaled through the test device for about 30 seconds. The ammonia sensor was then photographed with a smartphone camera and the color response analyzed by the RGB values and compared to the bun level. The top plot presents the urine test R value versus blood Phe level for each test sample for the urine test. The overall difference between the blood and urine test Phe values was only about 1.35 mg per deciliter. The lower plot presents parts per million of ammonia in the exhaled breath versus bun level, which shows high linear correlation for kidney disease patients. We are currently preparing a clinical trial for the urea cycle application. To conclude, we have developed simple, low-cost, at-home methods for both PKU and urea cycle disorder applications, and will be working to see both of these test methods through to commercialization. We would like to thank the following for funding and project support over the years, and especially the participants in the clinical studies. Thank you.
Our next talk is from a supporter of this meeting, Ultragenyx Pharmaceuticals, Deborah Marsden.
Triptanoin is approved in the US and Canada as a source of calories and fatty acids for the treatment of adult and pediatric patients with long-chain fatty acid oxidation disorders. Here, we describe the clinical course of US patients who accessed triptanoin during the emergency IND pathway using a retrospective review of medical charts 48 weeks before starting triptanoin when patients were treated with even number of carbon medium chain triglycerides, MCTs, and during 48 weeks while receiving triptanoin. 20 patients were included. Median age was 0.9 years. 12 were less than 1 year of age and 4 were less than 6 months of age. All patients had multiple concurrent MCEs. 7 had cardiomyopathy plus rhabdomyolysis, 3 cardiomyopathy plus hypoglycemia, and 2 cardiomyopathy plus rhabdomyolysis plus hypoglycemia. 6 died due to progression of underlying diseases. Results: the average left ventricular ejection fraction improved 3.2%, and average creatine kinase decreased 487.5 units from before triptanoin initiation to during triptanoin treatment. The weight-based caloric intake and the caloric intake from MCT was similar before and during triptanoin. 13 patients had at least one serious adverse event, of which 2 were considered related to triptanoin. In conclusion, triptanoin was associated with improved cardiac function and decrease of serum creatine kinase in a study population of patients with LCFAOD and life-threatening major clinical events of metabolic decompensation in critical care and emergency settings.
Our next presentation is from Dr. Roberto Mendez of Duke University.
Hello, my name is Roberto Mendez. I'm a second-year clinical biochemical genetics fellow at the Duke Biochemical Genetics Lab. I'd like to talk to you today about one of my research projects titled Urinary Glucose Tetrasaccharide Correlates with Phenotype in Pompe Disease in the Newborn Period. Pompe disease may present phenotypically as infantile or late-onset Pompe disease, that is IOPD or LOPD. Individuals with IOPD benefit from early treatment. Enzyme activity assays are typically used for biochemical diagnosis, but are unable to differentiate between IOPD and LOPD. we propose the glucose tetrasaccharide GLUC4 as a potential marker to distinguish between IOPD and LOPD in early infancy. To test this, we performed a retrospective review of anonymized lab results. We had 170 cases with an average age of 14 days. We used the stated parameters to assign each case to one of 4 cohorts. GLUC4 was measured by UPLC MSMS. Here we see that an enzyme activity assay in dried blood spots does not differentiate between IOPD and LOPD individuals. A general trend is observed, but the groups share overlapping ranges. Here we show that urinary GLUC4 is only elevated in the IOPD cohort. The IOPD cohort is clearly separated from the LOPD cohort. We have shown that GAA activity can reliably exclude unaffected individuals from Pompe diagnosis, but cannot distinguish between IOPD and LOPD individuals. Urinary GLUC4, however, can make this distinction during the newborn period. By combining these assays, we can provide timely and specific diagnoses in Pompe cases and improve patient outcomes. For more details, please see our poster online or reach out to me by email. Thank you.
Our next presentation is from Allie Mary Hugh of Greenwood Genetics Center.
Hi, my name is Allie Merrihew, and I am presenting our research on the efficacy of telegenetics, a diagnostic yield comparison between in-person and telemedicine pediatric genetic evaluations. Our primary objective was to compare in-person pediatric genetic evaluations prior to the onset of COVID-19 to virtual visits following the implementation of COVID-19 protocols at Greenwood Genetics Center. We compared demographic data, clinical data, as well as clinical assessment outcomes and genetic testing outcomes between these two groups. Our primary objective was to identify if there were any differences in the diagnostic yield between the two populations. Although we saw some statistically significant differences in the demographic data, specifically in the self-identified Hispanic patient populations, as well as clinical assessment outcomes regarding patients who were diagnosed with isolated anomaly or features and those who were regarded to be within normal variation, we did not see any significant differences in the genetic testing diagnostic yield between the two groups. Furthermore, even with the differences seen in the clinical assessment outcomes, this did not have a significant effect on the overall diagnostic outcome for patients seen in person when compared to those seen by telemedicine. Our research supports the effectiveness of telemedicine across a broad range of pediatric patients when compared to in-person genetic evaluations and could be used to justify the use and utility of continuing to offer telemedicine services to patients, which in turn may improve access to genetic services.
Okay, our next presentation is from David Nguyen of Stanford University School of Medicine.
Hi, today I'm going to talk about Parkinson's disease and a related protein called miR1. miR1 is an outer mitochondrial membrane protein which is integral to mitochondrial homeostasis and apoptosis. So how are the two related? Previous studies have shown that eliminating miR1 from the surface of damaged mitochondria is a prerequisite for mitochondrial clearance. Furthermore, the PD-related proteins such as PINK1 and PARKIN are molecular companions that aid in the removal of miR1 from dysfunctional mitochondria. Our lab has previously demonstrated that miR1 is resistant to mitochondrial depolarized induced degradation in fibroblasts from a large number of PD patients and several at-risk individuals. As there is a lack of a reliable molecular marker for Parkinson's disease, our aim is to determine whether miR1 is useful for labeling individuals at risk for PD. We received 87 stem cell lines from the Michael J. Fox Foundation, and after placed in culture, we supplemented CCCP for 6 hours. CCCP depolarizes the mitochondrial membrane, and after 6 hours, we measured the miR1 protein expression levels via Western blot and ELISA. Our data suggests that after 6 hours in the healthy control, there's marked degradation of miR1, while after 6 hours in the asymptomatic genetic carrier and also the PD cell line there is a lack of degradation of MIR1. Similar observations were seen in our ELISA assay with our samples. In conclusion, there's a significant association of the MIR1 defect with PD patients and asymptomatic genetic carriers. Finally, MIR1 is a promising molecular marker for detecting both PD and at-risk populations. Tracking the MIR1 marker could aid in diagnosis and MIR1-based drug discoveries. Thank you.
Our next presentation is from Dr. Rod Nowakowski of Vision America of Birmingham in Alabama.
Greetings from Vision America of Birmingham. We have no disclosures. Vision America is a multi-specialty medical surgical eye care referral center. The genetic service was converted to telegenetics in July of 2020, and we used a Microsoft Teams HIPAA-compliant platform. For the first 56 visits, ages ranged from 1 to 79. Average distance from home address was approximately 80 miles. Tests were ordered online, buccal swab kits were shipped to patients, and a follow-up telegenetics visit was scheduled for counseling. 100% of home-collected samples were testable. Screen sharing proved effective for explaining test results. The display is enlargeable for visually impaired patients. Misunderstanding of telehealth resulted in 2 patients confirming a telehealth visit yet showing up at the office. Some patients took advantage of not being physically present by sitting in a fast food lane, driving to work, or having their oil changed. Unlike the office, you won't necessarily know everyone who is present unless they speak up or move into camera view. I quickly learned to ask, "Who's with you today?" 4 referrals were made for clinical trials. 1 patient received gene therapy for choroideremia. 1 patient and father had a medically actionable, potentially fatal secondary finding. Exposure risk was eliminated. Miles not traveled for care were about 6,000. There was no indication that appropriate care or testing could not be provided via telegenetics. Telegenetics will continue to be an effective option post-pandemic. That's all. Thanks very much.
Okay, our very next presentation is from Hannah Olive of the University of Alabama at Birmingham.
Hi, my name is Hannah Olive, and I'm a genetic counseling assistant here at UAB. This poster is the result of a quality improvement project that stemmed from a lack of consistency in screening patients with hemihyperplasia and macroglossia. We implemented a screening protocol that included an AFP level every 3 months until age 4 and a renal or abdominal ultrasound until age 8. A GCA compiled a list of patients who needed screening, contacted them in the month screening was due, and relayed the results to providers and families. Figure 1 illustrates that in the last 18 months, we have seen 100% of patients complete at least 1 screening, and a majority of patients completing more screenings. Figure 2 depicts the increase from 33% to 82% of patients that have completed all ultrasounds in the first 7 months of using the protocol. Likewise, Figure 3 shows the increase from 14% to 78% of patients completing all AFP levels. Overall, we have seen a higher rate of consistency in monitoring patients and the benefit of incorporating a GCA into the workflow. As the protocol continues, we look forward to collecting patient feedback on its effectiveness. For any clinicians looking to implement a similar protocol, I've included some tips. Each family differs in their understanding of the patient's need for screening, distance from a screening location, and scheduling preferences. For example, some families prefer to set up all 4 screenings for the year at once, while others prefer 1 call when each screening is due. Identifying these barriers and meeting the families where they're at has been crucial. I've also learned to contact the patient early enough to allow ample time for our scheduling team to process the order and coordinate with radiology. Reminding families of the appointments has increased follow-through. And lastly, communication about results and who will be designated to inform the families is important. If you have any questions about this project or how to help a GCA integrate it into your clinic, please contact me. Thank you.
Let's add that Hannah Olive's contact information is on her slides on the SERGG website. Her video inlay covered up her email address on the presentation today. Our next presentation is from Dr. Marty Porter of Horizon Therapeutics.
The nitrogen scavenger drugs approved for the chronic treatment of urocycle disorders, or UCDs, contain phenylbutyrate, which undergoes hepatic conversion to phenylacetate, or PAA, which conjugates with glutamine to form phenylacetylglutamine, or PAGN, for urinary nitrogen excretion. Elevated PAA is associated with reversible neurologic symptoms similar to hyperammonemia, such as headache, nausea, vomiting, and lethargy. Given the variability of plasma PAA levels, PAA to PAGN ratio has been identified as a useful metabolite test to monitor and guide dosing. Here we present findings from a survey assessing clinicians' use of the metabolite test that we conducted with Dr. Sutton of Baylor University and Dr. Fichiglu of Children's Hospital of Pennsylvania. Our sample consisted of 52 U.S. clinicians who treat patients with UCDs. 58% reported that they have ordered plasma phenylbutyrate metabolite testing. 57% of test users reported that they typically only order the test on an ad hoc basis, while the remaining 43% order the test regularly. Test users reported that the results are most often unremarkable or suggestive of poor treatment adherence, while results indicative of PAA toxicity are uncommon. Nearly half of test users reported that they were not sure about what PAA to PAGN ratio to target. Those who do not order the test regularly were more likely to be unsure of their target. Finally, 1/5 of test users reported that they have uncertainties about the test, most often regarding how to interpret the results. These findings demonstrate a need for improved awareness of published data, including the relationship between PAA to PAGN ratio and the risk of PAA toxicity. For example, a ratio above 2.5 is associated with elevated PAA, and thus represents a useful measure for considering phenylbutyrate dose adjustments to achieve UCD management goals.
Our next presentation is from Antonio Ramirez of Ultragenyx Pharmaceutical. He is a supporter of this meeting.
Hello, my name is Dr. Mark Reynolds, and I currently serve as a clinical associate professor at the University of Alabama in Huntsville College of Nursing and as vice president of Tyrosinemia Society. The title of my poster presentation today is Tyrosinemia Society, nonprofit organization created to advocate around the globe. Tyrosinemia type 1 is a rare metabolic disease characterized by the development of liver disease with neurologic events in infancy and may lead to death due to liver failure in early childhood if left untreated. Rare metabolic disease patients and families all over the world face challenges understanding the disease process, procuring necessary treatments, navigating the complex healthcare system, and connecting with related rare advocacy groups and organizations. In 2019, a group of volunteers with diverse backgrounds, including university professors, healthcare clinicians, and scientists, with a shared interest and vision in advocating for children and families affected by tyrosinemia, united to begin the extensive process of forming a nonprofit organization. With the assistance of the National Organization for Rare Disorders and spearheaded by nurses, the group agreed upon a name and centralized mission, vision, and core values. Multiple resources were consulted to assist in forming the new nonprofit organization, the Tyrosinemia Society. To date, the Tyrosinemia Society has made contact and advocated for patients and families affected by rare metabolic diseases all around the globe. Resources to aid in developing a nonprofit organization are provided to you in the chart. At this time, the Tyrosinemia Society has partnered with NORD, Codexis, and patients like me to educate, advocate, and improve health outcomes for adults and children with tyrosinemia and related metabolic disorders.
That was Mark Reynolds. And this is Antonio Ramirez's presentation from Ultragenyx Pharmaceutical.
Long-chain fatty acid oxidation disorders are a group of rare autosomal recessive mitochondrial diseases of fatty acid metabolism. Ultragenyx has developed a global, long-term prospective outcomes study called the Disease Monitoring Program to collect information on disease evolution and management from patients with LCFAOD for up to 10 years, regardless of prior disease management or participation in triptanoid clinical trials. The program consists of two studies: CL401, that utilizes in-clinic and phone examinations of patients' physical health, factors associated with rhabdomyolysis, cardiomyopathy, hypoglycemia, liver health, motor function, quality of life, major clinical events, serious adverse events, as well as nutritional management. The second study, UX007CL402, is a self-reported study in which patients complete a mobile or web-based questionnaire of disease status, including disease history and manifestations, major clinical events of metabolic decompensation, disease management and interventions, healthcare resource utilization, physical activity, and assorted patient-reported outcomes. A unique characteristic of the DMP is the planned sharing of data with the participants that will include both their own data and de-identified and aggregated data from all participants. This will provide participants and the LCFAOD community with direct feedback and support research efforts from academia, clinics, and industry.
All right, our next presentation is from Lindsay Ryan of Emory University.
Good afternoon. My name is Lindsay Ryan, and the poster I'm presenting today is titled New Directions in the Innovative Model of Online Training for Nutritional Management of Inherited Metabolic Disorders. I'll start with some background information on this topic. There's limited formal training available for registered dietitians specializing in the field of inherited metabolic disorders. The Electronic Genetic Nutrition Academy, or as I will call it, EGNA, was the first online program developed to meet this need. My objective of this poster is to analyze the participation in EGNA to better understand the learning needs of participants. Phase 1 of EGNA includes interactive, web-based case conference and journal clubs, online forum discussions facilitated by national experts, and medical commentary videos from experienced providers. Participants complete pre- and post-tests for each session, receiving certificates of completion for up to 4 continuing education units. Data were collected from 11 sessions across 4 years covering a variety of topics. Worldwide registration has increased from 266 in year 1 to a total of 1,155 by year 4. To date, 538 people have participated in EGNA during live sessions, with 46% participating in the case conference, 25% in the journal club, and 28% in both. Certificates of completion for 388 CEUs were awarded to participants who completed both the pre-test and post-test, including 53% of attendees for case conference and 47% of attendees for journal club. Given that more participants chose to complete case conferences over the journal club, we conclude that there is a greater worldwide interest in learning about IMDs through a case-based approach. Based on these observations, we've expanded EGNA by utilizing Project ECHO to create a cohort-based case learning platform. The next phase of EGNA will include a course that incorporates didactic modules and case-based learning. Thank you.
Our next talk is from Maria Schoen of Emory University.
Hello, my name is Mariah Schoen, and today I'm discussing a study that focuses on females with PKU who participated in integrative health intervention within a camp setting. And this study used high-resolution metabolomics to better understand how this intervention impacted the plasma metabolome of these PKU participants. And this study had two objectives. The first was to compare the PKU metabolome to that of a sample of demographically matched controls. And the second objective was to look at changes in the PKU metabolome following the 5-day camp intervention. And for our results, we first found that relative to controls, Phe catabolites, ketones, carnitine, and glycine conjugated fatty acids were prominently elevated in our PKU sample, whereas fatty acetylcholines were substantially reduced. And following that camp intervention, our PKU participants showed a notable decrease in Phe concentration, as has been previously shown. And there was a large improvement in dietary adherence, which we observed in 70% of the sample. And these alterations were reflected in the plasma metabolome. As you can see in figure A, there's a separation between that day 1 profile and day 5 profile. And the metabolites found to contribute most to the separation were those associated with the metabolism of Phe, tyrosine, tryptophan, histidine, ketone bodies, steroids, and choline. And overall, this analysis identified prominent perturbations in amino acid and lipid metabolites within our PKU sample that are known to be associated with bioenergetic impairment and oxidative stress. And while this intervention was short, it did have an important impact on these discriminatory metabolites by improving the profile to match that of the controls. And finally, our metabolomics identified choline derivatives to be an important differentiator between our treatment groups and also highly responsive to this short-term intervention. And this group of metabolites has not been studied much in PKU before and has a very important implications for neurocognitive health. And thus we hope to further study the impact of choline in this population.
All right, our penultimate presentation is from Marie Smith of Clemson University.
Phelan-McDermid syndrome is caused by a deletion mutation in 22q13 or pathogenic mutations within SHANK3. The prevalence of lymphedema in the PMS patient population has been estimated to be around 22 to 29%. The goal of this study is to understand the epidemiology of lymphedema in a Phelan-McDermid syndrome cohort and identify potential genes associated with the disorder. This poster shows the beginning process of this study. The data was taken from the PMS registry and divided into two parts, genetic data and clinical data. The clinical data was gathered from extensive patient-reported questionnaires in which the demographic information as well as lymphedema-specific information was filtered out and went through extensive data cleaning. In terms of genetic data, microarray and other results were gathered from the registry. These results were then categorized into chromosome 22 abnormalities and deletion size. All the breakpoint data was converted to the same format, HG19. The results can be shown in these figures as well as in the QR code below if you scan it and follow the link. Figures 1 and 2 show the clinical data breakdown. The first central figure, figure 1, shows the prevalence of patient-reported lymphedema associations per registry patient. These associations are defined in the results section. Figure 2 gives a general prevalence breakdown of patients who have received some sort of formal lymphedema diagnosis. The figure under that, figure 3, shows genetic data in terms of the prevalence of the categories of chromosome 22 abnormalities in patients with array data and confirmed SHANK3 deletions. Identifying a genetic cause for lymphedema in a Phelan-McDermid syndrome cohort may allow for appropriate diagnosis and management. Because of this, our next steps are to link the genetic data to the clinical data for further analysis, to further analyze the association of age and lymphedema in the cohort, and to identify potential associated genes. Thank you.
And our final poster presentation today is by Dr. Haiyue Zhang of Duke University.
Hello everyone, my name is Haoyue Zhang from Duke University Biochemical Genetics Lab. In this meeting, we have a poster presentation about isotope dilution, UPLC-MS-MS quantification of amino acids in dry blood spots and plasma using Carol's amino acid kit. In this work, we validate an UPLC-MS-MS method for DBS amino acids, established age-specific reference ranges for DBS sample type. We compared amino acids concentrations between DBS and plasma. The method is straightforward. Extract DBS in methanol, followed by filtration cleaning, then AQC deratization. Samples were analyzed by LC-MS-MS. In less than 10 minutes, 31 amino acids, 21 internal standards, including isomers, isoleucine, L-isoleucine, leucine, were separated. The assay has required accuracy and precision for the analytical range between 2.5 to 2000 micromolar. DBS phenylalanine, valine, tyrosine, isoleucine, leucine were linearly correlated with plasma. Patients with inbound errors of metabolism require routine monitoring of amino acids. Home collection of DBS will facilitate this process. Thank you for your attention. Please visit our poster online. Bye-bye.
Okay, and that concludes the 2-minute presentations. Nina?
Thank you, Adria.